We know how important it is to care for your hormones and your overall wellness. But what happens when you feel so tired you can't move? Your hair is falling out, you're constipated daily, your anxiety and depression spirals out of control, and you can't stop gaining weight. I want to introduce you to my friend, Sophie Shepard, founder of She Talks Health. She is a thyroid, gut, and hormone expert who has helped hundreds of women get to the root of their health issues holistically. Sophie knows exactly how it feels to struggle with her health after dealing with IBS, Hashimoto's, anxiety, and painful periods all before the age of 22. Through a unique approach that addressed her mental and physical well-being, Sophie was able to reverse her symptoms and thrive. Now she teaches other women how to take back control of their health too. And she has a special offer for our listeners. So head to the show notes to apply for a totally free health strategy call with Sophie to finally get to the root of what keeps you from fully thriving. I do want women to know that there is an alternative to suppressing their bodies with hormones, that they can see their body as a good and they can live in that body holistically.
Totally. Oh my gosh. It's amazing.
Join co-hosts Jamie Rocci and Teresa Kenney as they educate women about the beauty of the feminine design and empower women to take charge of their health.
They're going to be so amazing. You're going to be so empowered by understanding your feminine genius and your hormone genius. I don't think I could live my whole life knowing this and not sharing it with anyone.
Hello, everyone. Welcome to the Hormone Genius Podcast. I'm here with my co-host, Jamie, and we're going to talk about two conditions today and how you can understand the difference between them. And the reason why we're doing this episode is because as a nurse practitioner who has treated lots of patients, I find that not only are patients confused about these two issues, but doctors and healthcare professionals are also confused. And so this will allow you to be empowered as the patient to advocate for yourself. And this is what we really believe at the Hormone Genius, is that patients who are well educated about their cycles, about their hormones, are going to be able to advocate to their healthcare professionals that they deserve better, that they deserve a root cause approach to treatment of health. So the two conditions, Jamie, that I want to talk about today are Polycystic Ovarian Syndrome, PCOS, which we've talked about before, and Hypothalamic Amenorrhea, or HA. So they both kind of have acronyms, PCOS and HA. And the reason why this is really important is because, again, there are similarities to these two issues, so much so that, again, many doctors don't understand how to really discriminate when a patient has one versus the other. We also haven't talked as much about hypothalamic amenorrhea. And so I want to dive in a little bit deeper on that one, because that's a condition that often affects a lot of women. In fact, I was surprised to know that it's estimated that 1.6 million women in the United States have HA, or hypothalamic amenorrhea. And it's a third of the cause of all cases of what we call secondary amenorrhea. That just means that I had my period, I started my period when I was young, and then I lost my period and it hasn't come back. So again, trying to look at the two differences of these things. So I'm going to start with hypothalamic amenorrhea, Jamie, but just from what you know about those conditions, I think my guess would be, Jamie, you understand probably PCOS a little bit more, but give me a sense of where your knowledge base is on kind of these two areas.
When I think of HA, I think about women who've lost their period because they have like low body mass index, like they don't weigh enough, they're over working out, and it's like this protective mechanism of the body. The body wants to survive more than it wants to ovulate. So that's always what I've thought of when I think of HA. I think about that, but I am sure that there are a million other things that I can come to learn, and I could see where that could be confused for PCOS, kind of, because again, we know with PCOS, there's the two of the three things that need to be present, which you'll talk about those, but how often it's kind of maybe easy to assume that PCOS may just be a certain type of person, whereas there are other women who have PCOS where they call it, quote unquote, skinny PCOS or whatever. And so my question too, in that case could be, is it really the HA thing? So I would love to learn and really dig in between, how would you define, Teresa, for our listeners, what these two things are, and how would you maybe share like what a patient coming into you might present as, and how it could be confusing for the medical professional, and then how you approach those cases.
Yeah. And I think you're right, Jamie. There is the kind of what we assume the person would almost look like, present like, and that can get us into trouble, totally, in terms of discriminating between these two, because, and this is true of PCOS and HA, that it isn't always what we expect. Mm-hmm. So let's just talk about what are the things that are similar in terms of a person walking through the door. So I'm a patient. I come to my healthcare practitioner. I'm 18 years old, and I had my periods all the way up until that point. They were regular. I went off to college, and all of a sudden my periods started to become more irregular, and they just disappeared, basically. So a patient in that situation, here we have secondary amenorrhea. I had my periods and now I don't have my periods. What is the reason? Mm-hmm. So it could be either or in terms of conditions. Now, I always want to say, like, we want to rule out other things too. Like there's other things that cause secondary loss of periods. So you got to rule out thyroid and other things, but we're just going to focus on these two conditions. So I present with having either absence of periods completely, or my periods might just show up every once in a while. And then you might also have symptoms like maybe I'm more tired, maybe my hair is falling out, maybe I just am having more depression or anxiety. And again, this would be similar potentially of both cases. And then if also we were to look at that patient in terms of what's going on with her reproductive system physically, and this is where a lot of the confusion can come, is both of these patients, HA and PCOS, will have cysts on their ovaries in the exact same pattern. And I would say this is what confuses people most of the time. And then we'll go through kind of lab work as well. But both patients, if you do an ultrasound of their ovaries, will have multiple collections of small undeveloped cysts. Why? Because they both don't ovulate. Both for different reasons, but because of lack of ovulation, it'll create an ovary that looks polycystic. So we cannot use the ultrasound always to diagnose. And a lot of doctors, again, they just might look at a patient. Oh, you don't have your period. Oh, we did an ultrasound. You have cysts on your ovaries. Obviously, you have PCOS.
Right.
So we have to look at lab work then. And in lab work, it will be able to really help us figure this out. So we have hormones like FSH and LH. These are the two pituitary hormones. Jamie knows, obviously, these regulate the menstrual cycle. They come from the pituitary in our brain. And in PCOS, LH will be often higher than FSH, often greater than the number 10. And the FSH will also be normal to on the kind of like average 5 to 10. So LH will be at least 2 to sometimes 3 times higher than the FSH. We often call that the ratio between the LH and the FSH. Normal FSH and LH should be in a 1-to-1 ratio. PCOS, LH will be higher than the FSH. What happens with hypothalamic amenorrhea? Well, in hypothalamic amenorrhea, the LH and the FSH stay usually in a 1-to-1 ratio, but they're also lowered because of inactivity. And that's because of how hypothalamic amenorrhea occurs. So both of those will be low. And then in another hormone would be estrogen. In PCOS, usually estrogen is normal to kind of average to higher. And the estrogen in hypothalamic amenorrhea, very low. In PCOS, the thyroid can be off. It can be high or hypothyroidism, but also in hypothalamic amenorrhea, there's some changes that occur. Usually it's the T3 that goes much lower. And in the aspect of what we call androgens like DHEA and testosterone, in PCOS, those will be higher because PCOS is associated with increased androgens or male-like hormones. And in hypothalamic amenorrhea, they'll be very low. So we'll have more of a trend of low hormones on the hypothalamic amenorrhea and potentially some changes in the PCOS of higher hormones. And so that can really help us figure out whether something is PCOS or HA. And then lastly is the progesterone challenge. This can also help us. If I give somebody with PCOS progesterone for 10 to 12 days and then they stop, almost always they will have some sort of a period or bleeding. In hypothalamic amenorrhea, because again, the estrogen levels have been very low, if I give them 10 days of progesterone, they may not bleed at all. And we call that a progesterone challenge because it is kind of a challenge to kind of see how much estrogen does this patient really have? If they don't have hardly any at all, they just won't get a period after giving them progesterone.
Super interesting. And such a relief for any of the medical professionals listening who work with patients to know that these things that you can do to help understand the difference between the two are easy, somewhat easy. I mean, for you guys to be able to manage, and how much of a difference that would make for the patients you work with. I mean, holy moly. Okay, quick question about the PCOS, the LH and the FSH inversion, like the flip-flop. How would you explain that in terms of the brain? So if the LH is higher than the FSH, because normally, again, that's not the case. The FSH is higher on the front end of the cycle. The LH surges, that marks ovulation. How do you describe the brain at that point?
Yeah, I mean, you can think about it from a couple of angles. Number one, PCOS, because of the underlying cause of PCOS, which is inflammation, increased insulin levels or insulin resistance, and increased androgens, those influence the LH to trend higher. So literally, like, it's a cascade, almost a domino effect of hormones. The increased insulin, increased androgens. So it starts with the insulin resistance, which pushes up testosterone and DHEA, which pushes up LH in a sense. But you could also look at it as, if the body is trying to ovulate, but it's not working, then the brain is also kind of triggering an increased LH because of it trying to send the message over and over again.
Yeah, totally.
So it's kind of a both and in that situation.
Got it.
And yeah, so that's a really great question with that one, Jamie. And it gets us to the heart of PCOS, which again is different as an underlying cause. I mean, PCOS, most common disorder of women, hands down, between the ages of 45 or 15 to 45, PCOS is the most common women's health endocrine disorder. So this is truly what we're going to see the most. And I also think that can be a reason why doctors tend to kind of quickly make that diagnosis. I mean, I've seen patients where I'll ask them what sort of workup was done to tell you have PCOS. And they're like, well, I just told them I didn't have my periods anymore. And, they just looked at me and they're like, well, you have PCOS. So they can be very quick to kind of make that diagnosis. Interesting that both of them also kind of lead to kind of these mental health issues. They're both associated with kind of an increased risk of depression and anxiety. But PCOS has an additional kind of risk of changing their health risks overall to more of a profile of diabetes and cardiovascular issues and infertility, also vitamin D deficiency. But they both can lead to infertility because both lead to lack of cycles and ovulation as well. So they're both going to need help with infertility if they have it, but in completely different ways.
So for the HA girl, she comes in and you're running these challenges and you're figuring it out. Okay, this gal has HA. What may be the cause? What may be causing HA? And then how do you help her get back on track?
Yeah. So glad you asked this. So the way I describe it, Jamie, is that this is a situation of under generosity of energy. So the body is always in an energy balance. What it needs is to know and basically to have homeostasis, kind of a sense of health and well-being, It needs to know that energy is coming in efficiently and it can be used then appropriately.
Right.
And this is an issue of energy balance. So when people develop HA, it's because the body is sensing an undergenerosity of energy balance. Sometimes I'll say it's an undergenerosity of nutrition. What's interesting to me about HA, Jamie, and this particular patient is many times they are very unaware of why this is happening because they see themselves as incredibly healthy and not restrictive. And this is where you really have to tease out kind of where this undergenerosity is coming from. So often I'll ask questions like, do you plan your day around when you need to exercise? Because exercise equally is an issue, and in some ways more, I feel like, equally in terms of causing this. Again, over-generosity of exercise leads to energy balance. But if I say to a girl, what if I told you that you needed to stop exercising for 2 weeks? How would that make you feel? And if I can see on their face an instant kind of like anxiousness, then again, it leads me towards this diagnosis of HA. Another question I might ask is, do you feel bad when you miss a day or two of exercising? Do you plan your day around kind of what you're going to eat for the day? Do you kind of look at your nutrition and think about, am I going to, strategize kind of what's healthy eating? It's very much kind of like a type A personality, somebody that, kind of is like overachiever, very high achieving people. And the last one would be, do you use exercise to cope with stress? Because more often than not, when patients with HA, they don't think they exercise too much. What they think is that's their way of coping with stress. They see it as a healthy thing because they need a way to cope with stress.
Right.
So think about those things out there listening. If you don't have your periods and any of those questions kind of triggered you at all, this might be a thing. You might be a normal body weight. That's the other thing, Jamie, is again, we think of it as like a lower BMI, which does correlate with that. That is true. But I've had patients with very normal body weights, but they still fit into this. I exercise a lot. I'm really focused on my health and nutrition. So they tend to eat really healthy and kind of not a lot of, fast food or anything bad. And they use exercise as a coping mechanism for stress. Their periods have gone missing. And this is kind of what it's done is this undergenerosity of energy has told the pituitary that you are not capable of reproducing because it sees it as a stress. And even, with HA, the cortisol levels they see are higher. That hormone called ghrelin is higher. And we see decreases in insulin growth factor and decreases in this hormone called kisspeptin, which is a regulator of the gonadotropin releasing system. And so they can see these changes, and it really is based on this stress that is occurring, but the patient themselves really doesn't think they're stressed. Yeah. Oftentimes they don't recognize that.
It's interesting because as you're explaining this, I think about all of what you were sharing about, and I love that whole idea of undergenerosity. That's a good way to describe it and to think of it. But I think about the woman who still has those tendencies of thought, maybe still having a difficult time achieving pregnancy. Maybe they don't have HA, but maybe they're headed in that direction. I don't know. But, I've worked with a number of type A, and I could say myself like years ago, but I never ever missed my period, but I can imagine that it probably wasn't good for my body. And so at what point, is it kind of like the tipping point? I think about that a lot. At what point does that cup, that one drop, flows over the edge and now you're into this HA land? So what are some maybe warning signs or things just for women to be aware of if they are like really hyper, they love to work out, they're kind of more type A, really aware of diet and exercise, because that's all great. But there's a point in which, it's not good for the body and the hormones. So what would you say?
Yeah, and that's true, Jamie. I mean, again, these are healthy things that we're told constantly every day of our lives.
Yeah,
exercise, eat healthy. So when we know that it's gone off balance, is the cycle, is really a great measure of that for most people. However, Jamie, like you said, you didn't lose your cycle, but when you think about those things that I talked about, you kind of feel like,
oh yeah,
I fit into that. And Jamie, I did too. In college, I became an over exerciser. And if I missed a day or two of doing my thing, I felt guilty. I felt like I would wake up a different person.
Yeah.
And those aren't healthy things. Again, if you can't take a day or two and just completely relax without it triggering some sort of anxiousness, that's not a healthy relationship with a healthy thing.
Right. Right.
And that's the key is, Jamie, there's no way to know who will lose their periods and who won't necessarily. There probably is some epigenetic factors, some genes and stuff that make it more likely for certain people. It may have to do with, kind of the way their hormones have become imbalanced, and that can be different for every person. But the fact is, if it happens to you, no matter what, even if you don't think you are exercising too much or you're not eating enough nutrition, that's what is happening. And we can see it in those labs when we see this very low estrogen, very low FSH and LH, the thyroid getting lower. We can see that your body is struggling.
Yeah.
How do we help this then, Jamie? And this is the hardest part. The hardest part for HA patients is that in order to reestablish this pacemaker, this GnRH pituitary pulse of hormones, the body needs to sense now an overgenerosity of energy, an overgenerosity of nutrition. And for these patients, that can be incredibly difficult. And so there is so much support. I feel like now, I was listening to a podcast recently, I'm blanking on the name of it, but it was a support group in a sense for HA and a lot of information about HA. And I would say a functional nutritionist would be a great support for an HA patient. You really need someone to really help you kind of guide through this. You can get your period back, but it's going to take a lot of effort to slow down the stress hormones in your body. We have to re-signal to the body, again, this overgenerosity of energy. And in order to do that, that means really slowing down the exercise, making sure that you're getting adequate nutrition and adequate fat, because we know that fat is what is the kind of precursor to producing hormones. And it doesn't have to be unhealthy. And I think that's the other thing. It doesn't have to be like I'm downing now burgers or anything, but you likely will have to gain some weight in order to reestablish the pacemaker. It's not always the case, but for many people, it will be that if you're sitting at a lower body mass index, which a lower body mass index would be anything under 21, it doesn't mean that's unhealthy, like I said, but because of your situation of shutting down the periods, in order to reestablish it, sometimes, again, you need an overgenerosity. So we need to push that up a little bit more. And I've seen people reestablish their periods, but it's not something I can do for them. It's something that they do for themselves, and they do it with the guidance of people supporting them and other patients who have gone through it. And that's why I think getting into these HA support groups and really find out what worked for people, can be really supportive to these patients as well.
Totally. And even thinking through, like, for you and me, Teresa, when we were in college, that's, again, what we saw all around us. We saw people eating really healthy, working out really hard. And that's kind of like maybe where we, drew our standard of health was from those earlier years. But I'm thinking too about how, but with that, like you were saying, like what I was saying, there was a distortion of body image, though, in my mind. And I know we've shared this earlier in episodes. And like, I needed a counselor, definitely. And it was through working with the counselor, he helped me realize that, again, I was using like the punishment of my body or the food as a way to cope with other difficulties in my life. It was like my area that I could control, So I can imagine, let's say I hadn't gone to the counselor and worked through that, and me still having that way of thinking even to this day, it would have been rooted in this sense of trying to, fix or control something, and so really it wasn't until I kind of started to uncover, why am I so wanting to control over this? So that's what I would say too, for the ladies that you're working with, Teresa, like thinking about, the percentage of women that you could imagine, or maybe, have had some maybe distortion of thought or maybe past eating disorders, and thinking about the importance of a therapist working through, that food, that control over food and working out.
That's such a great point. And I often kind of relate it to like, what is your sense of identity in? Yeah. And I think when we're in college, this seems to be a real strong place for when this can happen for women. I think we are struggling to find who we are and what is our identity in. And for me, it
100%.
became, my identity was a soccer player and being fit. And I was putting all of my eggs in that basket. And it's also makes sense. Like, we haven't figured out what we're going to do with our life yet. Right. We're in college and figuring out our lives. So it's really what you put your sense of identity in. And we know that when it's put in something that's a material or a body image thing, it is going to cause some issues, probably. Like, our identity should be in who we just are as a human being, and how we are loved and how we love other people is really where identity comes from.
Yeah. What's interesting is I just finished a program, Charism Coaching, through Many Parts Ministries. I finished at the end of December. If any of you guys love thinking about that stuff, visit manypartsministries.com. But anyway, they talk about how finding our sense of identity can often come in three ways. One, we form our identity, or we find our sense of identity within our relationships. We find our sense of identity within our accomplishments, and we form our sense of identity within our failures or our difficulties, And so I think we could go in through each, but I'm going to say that the accomplishment piece would be the piece like, oh, I've accomplished this. That's who I am. For the difficulty, it could be, oh, I'm an alcoholic, for instance, which someone's not. They may struggle with that, but they're identifying with their struggle, and their relationship might be, I'm a wife, a mother, which are all really good. But until we're not a wife or a mother anymore, let's just say something happens, who knows? Then what happens to our identity? What happens to our identity when running or working out is taken off the table? I remember in college, I wanted to join the Peace Corps. And so I had already gotten to like the interview phase, and where I was placed for South Africa. I was going to work with people who had AIDS. And I asked the question, will I be able to work out? Like, can I run? Jamie, like, I'm in South Africa, like helping these AIDS. And they're like, well, no, you probably couldn't or shouldn't. Like, it would be unsafe for you to just go run, wherever. And I'm thinking, well, I can't do this then. That's how intertwined, even beyond this mission heart that I had to serve others. Like, I'm saying. So I wanted to say that.
That's a perfect example of that, Jamie.
Perfect, right?
The way you thought about that situation, that's how a hypothalamic amenorrhea patient would think.
Right.
Exactly. Yeah. It's just that for them, they've lost their periods because of it.
Right.
And, people will ask me, well, what's wrong with not having a period? And the problem is like, we've talked about hormones so much in this podcast, but like, your hormones are really important to your health. And over a period of time, you can actually lose bone density. And that's one of the biggest factors in relationship to not having periods at this point, especially when you're young and your bones are still reaching their peak bone density. If you haven't reached that yet, and you're compromised with not having your period, those hormones help keep bone production. Yeah. There's that. And then even I mentioned that PCOS, there's a risk for cardiovascular disease, but it's for a different reason. But for HA patients, there's a risk for cardiovascular disease because of lack of estrogen, which protects the heart. And they've studied women who have had HA for a long time, and they are at a higher risk of cardiovascular disease outcomes. So these are just important to our health. And we don't want to scare you, but we want to get help. And so if a patient comes to me and they have HA, and let's say they've been trying to work at getting their periods back, but it's been a year and there's still no period, we probably are going to need to put them on some hormone replacement therapy. And it can be bioidentical. That's the thing. It doesn't have to be birth control pills, right? For all of you out there. This is often obviously PCOS, birth control pills are offered all the time. HA oftentimes offered as well, because it's just a way to kind of put in a pseudo cycle. And that the OBGYNs look at it as just that's their way of adding back hormones. But just so you know, you can do bioidentical hormones and treat PCOS and treat hypothalamic amenorrhea. For hypothalamic amenorrhea, it's going to look different because you're going to need both estrogen and progesterone replacement in many cases. With polycystic ovarian syndrome, many times all you need is the bioidentical progesterone. But both of them can lead to, actually having periods and, seeing the effects of those hormones really being replaced as a healthy thing, not as something kind of synthetic.
Totally. And just imagining too, for those who do have HA, how once they do start getting maybe these hormones, these bioidentical hormones, how much better they may feel. They may not realize perhaps how run down they are, or, even just dealing with the quote unquote, the anxiety, well, perhaps maybe replenishing some of those hormones will help to neutralize, some of that too, where you don't maybe necessarily feel the need. But of course, we know working out gives us endorphins, and that can be a runner's high, and that's a whole other conversation. But, perhaps these women don't even realize how good they could feel, when they are fully in balance, like you said.
And Jamie, so the last thing I want to talk about is just the fertility aspect. If somebody is married and they have either one of these conditions, polycystic ovarian syndrome or HA, hypothalamic amenorrhea, they're going to need help potentially with having a child. And it looks different. So with PCOS, in either case, there is some nutritional aspects. With PCOS, we're trying to help the insulin resistance. So you might need a nutritionist to help you with bringing down insulin resistance. And so that's a whole aspect. And we've done podcasts on that. With HA, it may be getting more generosity of nutrition, more healthy fats, and really reestablishing that fertility pacemaker. But if those things both don't work, lifestyle, you're going to need some additional assistance. With PCOS, we give things like ovulation induction medications like Clomid or Letrozole or tamoxifen to stimulate the ovaries to produce those eggs. In HA, that doesn't work. Right. Because the ovaries are completely shut down in terms of the ability to even be able to hear the messages. And so what we have to do is we have to, again, really help them to get those hormone levels back up on their own to reestablish that pacemaker. And if that doesn't work, then they need usually it's something called the GnRH pump, which is it's a very new kind of technology, but where you reestablish the pituitary hormones. And it's not done in very many places, but it's done at the St. Paul VI Institute in Omaha, Nebraska, where I worked for 20 years. There are some other people that do it, but they're also looking at using IV kisspeptin. This is a new thing that probably hasn't reached, again, doctors' offices. But for the most part, most HA patients are going to need support because they need to reestablish that ovulation, and they can themselves in most cases. And I also can build up their hormones over time, and then they can get to the point where those ovulation helping medications sometimes work. But, two different areas of help. And if you, again, need support, NAPRO technology, which we just did a podcast on, there are doctors trained in NAPRO technology who have a better sense of how to treat this from a holistic standpoint. And so, we can remind you where to find a NAPRO technology doctor in the show notes as well. But again, Jamie, this is a situation where I just want to make sure that if you're the patient and you've been told you have one of these conditions, I hope now you have a better sense of how you can make sure you have the right diagnosis too, and you're getting the adequate support and treatment that you need.
Right.
If you just go on the internet and put into Google PCOS versus HA and hit Google Images, you'll get a ton of these like little images that show what are the differences in terms of what I just explained. What are the lab work differences? What are the symptoms that people normally experience in both conditions, and where do they overlap? Because again, we know that they overlap in many ways. but where are the differences so I can really figure out what is it that I'm experiencing? Why did I lose my period? And how I can get the right treatment and support for this condition.
Yeah, such an important topic, Teresa. And again, I don't feel like, or it doesn't seem as though many people talk about this that much. We all, like you said, PCOS is this very common endocrine disorder and women struggle with this. But there are so many women who I know I've worked with who've lost their period completely and have been told PCOS. And so, now I just kind of wonder, maybe it's HA. So it is just good for our listeners to know, for those who do serve women to understand and know. And I think you did a really good job, Teresa, just laying out the differences between the two and giving our listeners a starting point.
Thanks for listening to the Hormone Genius Podcast. Please remember to share our podcast with your friends and family, and also follow us on social media. If you were not aware, we have a YouTube channel. So if you could like and subscribe to our YouTube channel to stay in the loop with all of our latest episodes, we would appreciate that. Thank you so much for your support. We are excited to journey alongside you as you discover the beauty and the genius of your hormones.